and welcome to PUBH 610, Introduction to Health Systems Policy and Management, a course designed by the faculty of the Department of Health Policy and Management with some help from our faculty colleagues in the Department of Environmental, Occupational, and Geospatial Health Sciences. If you'd like to know more about us, you can go to our website and read our bios. My name is Stacy Plichta, and I am a full-time professor of health policy and management at the CUNY School of Public Health and your instructor for this course. I'm a researcher studying the health and wellness of frontline social services workers. I'm a practitioner conducting workshops and trainings on health and wellness since 2016. I'm a mom to two terrific young adult women. I'm a passionate gardener, camper, and traveler, and I'm a fan of toasted almond ice cream. This class will help us to do a number of things. It'll help us to discuss the public policymaking process, to compare healthcare, public health, and regulatory systems across national and international settings, to apply principles of leadership, governance, and management to real-world situations, to apply advocacy, negotiation, and mediation skills to address organizational or community challenges, and to explain the basic principles of budget and resource management. But it's a lot to do. And before we start all that, I'd like to start us with a grounding breath. This is designed by Dr. Andrew Weil, who was one of the fathers of integrative medicine, and it stimulates the vagus nerve, helps us to relax and be centered. So I'm going to go ahead and talk through it. I'll demonstrate it once, and then I'll count it out so you all can do it. First, I'm going to place tip of our tongue just behind our upper front teeth. Belly breathe in a big breath for 4 counts. We're going to hold that breath for 7 counts. And this is important. Make sure you have enough breath to whoosh it out for all 8, like pace it. We're going to breathe out through our mouth, making a whooshing sound for 8 counts. And it'll look like this. Yep. Okay. Now, let me go ahead and count it out so you can do it. Put the tip of your tongue behind your upper front teeth. Breathe in for 4, 3, 2, 1. Hold for 7, 6, 5, 4, 3, 2, 1. Breathe out for 8, 7, 6, 5, 4, 3, 2, 1. Okay, I hope that was relaxing. And now that we're centered, let's get started. I'm going to cover a bunch of different concepts just on a surface level so that everybody's oriented to things we'll be talking about throughout the semester. And the first thing I want to talk about are models. We're going to be using a number of models in this course, 2 of them, the socio-ecological model and the She quad function model. And because we're using models, I wanted to talk about why. Well, a model is nothing more than a structured way to organize our thinking around a complex idea or system. The determinants of health are complex. All healthcare systems are complex. Models help us to simplify them, and it's important to remember they're just simplifications of reality. They don't capture every aspect of reality. Ideally, they capture the main aspects, but they help us to start thinking in an organized way about something very complicated. For example, here's this convertible, my dream car, and there's a model of a convertible in front of the real one. If I brought that model to class and said, "What's this?" all of you would say, "That's a car, that's a convertible," even though it's not. Doesn't have an engine, can't put the top down. I can't fit in there and go for a ride. But it's a model. It has enough of the aspects of reality. It has the wheels, it has the shape, it has the windshield, it has the top, that we can all identify it as a car. But it's not a car, and it's important to not confuse a model with the reality. When we do that, there's a word for it called reification. We start treating the model as if it's the reality. Remember, if the model doesn't seem to fully capture reality, it's because the model is just simplifying it and probably missing some pieces. For example, one of the models that we use a lot in public health is the socio-ecological model of health. If you've been in other public health classes, if you've been at the CUNY SPH for a little while, you've seen this before. If this is your first class, you will see this in many other classes. There are different ways of portraying it. I'm going to show two. And I want to point out that because it's a simplification, many of these versions leave out environmental health determinants. In each of these categories, there's some examples of what they are, but they're just examples. So I'm going to go ahead and talk through it. So the socio-ecological model of health says that if we know something, that all of these things are determinants of our health, that at the individual level, my knowledge, my attitudes, my beliefs, my behaviors, my genetics, all those are individual things. Those are going to help determine my health. But those aren't the only things, because my health is also going to be determined by my social capital, by my relationships with my family, my peers, my coworkers, my healthcare providers, my social networks. All of those relationships exist within organizational structures. They exist within my job, within my health insurance, within the healthcare system. They exist within my professional organizations, with health departments, with tribal urban health clinics, if that's a place I access care, with community-based organizations and other organizations. All of these organizations exist within the community. And in addition to these being part of the community is the built environment. It's my neighborhood. It's the transportation. It's whether or not do I need a car? Do I have public transportation? What does my house look like? Is it an apartment? Is it a standalone house? Is there green space? Do I have a grocery store nearby? Do I have a healthcare provider nearby? Do I have good schools nearby? All of those are things at the community level that in part determine how organizations function, in part determine my interpersonal interactions, and will absolutely have an impact on my individual health and individual behaviors. On top of all of that is this policy layer. Policies are laws, court decisions, and rules and regulations by local, state, or national legislatures, um, you know, and agencies actually, that create the space and provide the money to support things in the community, to support and regulate organizations, to support and regulate individual behavior. Another version of the socio-ecological model looks like this. And again, you'll notice, the core of this model is that the individual is at the core and that the individual exists within a social, family, and community network. And that social, family, and community network exists within living and working conditions. And those exist within broad social, cultural, economic, health, and environmental conditions. And that when we do interventions, we do them across one or more of these layers, one or more of these of determinants of health. And we're hoping for certain outcomes. And that, ideally, we're assessing to see our interventions getting the outcomes. And if not, we would revise our interventions. So that would be a way of, let's say, employing the socio-ecological model. But let's stop for a second and go, okay, why does this course matter? Well, this course matters for two reasons. First, if you're anywhere, if you're in this class, if you're in public health, if you're going to work in the healthcare system, or you're going to work in systems that affect health, on a very personal level, how money moves through the healthcare system is how you get paid. So understanding how that money moves is important. It's also important because unless we understand how money moves through the system, we can't change it. And if we want to work towards social justice, if we want to work towards health equity, towards people having access to the care that they need and access to the resources that enable them to be healthy where they work, live, and play, then we have to know how the money moves. So even if you're not in health policy management, if you're in this course because it's required, and you're an epidemiologist or a health educator or an environmental health person, knowing how the money moves through the system and knowing how to work for social justice will help you wherever you are. And I hope that this course is useful to you. And why public policy? We spend time on public policy because it's what creates the space and provides the money for what we do in public health and for how we regulate the healthcare system. Implementing social justice changes in society is expensive and usually depends on governmental and public action. The government is typically the only one that can take actions broad enough and impactful enough to make lasting and sustained changes. And governmental action starts with public policy actions. Policies are laws, rules and regulations, and court decisions. And we'll spend a whole class on those later. And why advocacy? We spend a class on advocacy because advocacy is action directed at making social changes. Once we have knowledge about how the healthcare system works, about how the money moves, and we can see what the problems are, if we want to make changes, we have to know how to advocate for them. And this is a skill you can use throughout your career. And especially now, the voice of public health experts is really needed to ensure that all public policy decisions, not just ones related to the healthcare system, reflect what's best for the public's health. But the voice of public health is not in public policy the way it needs to be. So hopefully through the skills that you learn in this course and other courses, you will be able to better advocate for health in all policies. And just want to talk about terminology for a minute. We talk about the health system versus the healthcare system. The health system is that broader range of determinants and processes that influence health. When we talk about the healthcare system, which is most of what we'll spend this class on, we're talking about more specifically the set of actors and activities primarily tasked with improving health status at the individual or population level. And within that, we're mostly going to talk about healthcare delivery, even though the healthcare system has other parts and certainly the health system has other parts. So what are healthcare delivery systems? These are the ways in which all societies, not just the US, provide services to meet the health-related needs of individuals. Ideally, they're like this beautiful watch. Ideally, they're a network of integrated components designed to work together coherently. Here's our second model that we'll spend some time with in this class. It's the She-Quad function model, and it's in your textbook. And the She-Quad function model says that healthcare systems, we can think of them as having four main aspects, four big pieces of their structure. And the first is financing, money. Because without money, how are we going to pay the healthcare providers? How are we going to get the healthcare settings? So the first part of a healthcare system is the financing. And this is not just in the US system. In all systems, money comes into, we can think of it as a big bucket. Comes from employers, comes from the government, which is really taxpayers. In the US, you can think of financing as coming from Medicare and Medicaid. They're also insurance. It comes from individual self-funding. Then there's insurance, right? And why insurance? Well, in financing, most of that money goes to insurance. A little bit of that money goes to healthcare delivery. So if you think about our co-pays, we pay those right to the doctor. Think about when we buy over-the-counter medicines, we pay that right to the pharmacy. But the bulk of the money that we collectively spend on healthcare goes to the insurance function because insurance is what protects individuals from catastrophic risk. And we do this by pooling our financing. Most people will not need that much healthcare in a year. Most people will pay more into the system than they need. And that's what we want, right? Ideally, most of us just want to go for our annual wellness visit, to get the vaccinations we need. And, if we get the flu or if we get a cut and need some stitches, we want to be able to get that. Some folks need a lot more care. They will have a catastrophic event. They will have an accident or a heart attack or cancer, or they will have a chronic disease that just costs a lot of money. And without insurance, they would not be able to afford all the care that they need. So insurance is what pays that money. But then we need a way to get that money to the providers. So there's payment mechanisms. So insurance companies have payment mechanisms to get the money to the providers. And we don't in this class spend a lot of time in payment mechanisms, but I just want you to know they exist. And finally, we have healthcare delivery. And this is where the healthcare workers, the settings they work in, and the care they can legally provide. That's where all of that lives. So what we typically think of as the healthcare system, the providers, is really just a part of the healthcare system. So what's the purpose of a healthcare system? Ultimate purpose is to improve the health of a population, to enable all residents to receive healthcare, to deliver services that are cost effective, and that meet established standards of quality. How does the US do? Well, if we look at this chart, not well. We consistently come in last in terms of how our healthcare system does in providing quality care, access to care, efficient care, and equitable care. We come in last every year. We've come in last every year for decades, and it's because our system is unique, and we will get to that. Now, the goal of any healthcare system, whether it's the US system or another system, is to provide preventive care, to have a prevention orientation to all people in the system, to provide quality care, and to be accessible. When we say quality, the Institute of Medicine has developed these 6 domains of healthcare quality that have pretty much been universally accepted. So when we're talking about care that's quality care, we're talking about care that's equitable. And equitable means that everybody who needs care has the same chance of getting the care that they need. The care is timely. People can get care when they need it. It's effective. It's evidence-based. It's efficient. It's the best care for the least amount of money. It's patient-centered. Patients have autonomy. They are educated. They're told about their conditions. They are educated about them, and they're the ones making decisions ultimately about what they want. And finally, it's safe, that the care itself doesn't cause unnecessary harm. Now, how should healthcare systems be centered and designed? The whole world got together in 1978 in Alma Ata, USSR, former Soviet Union, and had a conference. And the US was there along with 134 other largely representatives of countries. This is the origin, this conference, of the current globally normative thinking about healthcare systems, their functions, their goal, their structure. It's grounded in social justice. It establishes healthcare as a fundamental human right, acknowledges that healthcare has political and economic aspects. This is an important piece. It places primary care at the core of healthcare systems. And we in the US, we were one of the signatories to this Alma Ata Declaration. And the Alma Ata Declaration really focused on primary care and stated that primary health care should be the main focus of a healthcare system. It should be the centralizing force. It should be the first point of contact when people need health. They should first go to a primary healthcare provider, and that provider should be close to where they live and work, should be easily accessible. That primary health care should address the main health problems in the community, and the minimum set of services is here. That primary health care would promote individual and community self-reliance and participation in healthcare decision-making. That it would be universally accessible, that people would fully participate. It would be affordable. That when people needed referrals, they would get referrals through integrated functional and supportive systems, and that those who are in the most need of healthcare would get priority. And also that primary healthcare would be involved in other sectors to help coordinate efforts to promote health. Well, did it affect the US healthcare system? Not really. It had a limited direct impact on our system. Our system is largely focused on specialized care rather than primary care. We actually have more specialist physicians than primary care physicians. Now, Medicaid and Medicare, which predate Alma Ata, they're established 1965, but every year the laws that founded them are amended and they're improved. And the Patient Protection and Affordable Care Act in 2010, they did move the US closer to the vision of the Alma Ata Declaration. But the focus in the US is still simply on expanding health insurance. We're still market-based, and nothing we've done has meaningfully reformed our very fragmented system. We don't have centralized points of care. Which comes to, do we have a healthcare system? Not a good one. Our healthcare system, remember that really pretty watch I showed you a few slides ago? Kind of looks like this. We have all the pieces. We have financing, we have insurance, we have delivery, we have payment mechanisms, but they're unstandardized and they're only loosely coordinated. Our system is really functionally fragmented because it's not subject to overall planning. There's no central federal authority that plans our healthcare system, that directs it or coordinates it. Instead, we actually have a bunch of systems, not one. We're not a single system. We have no universal healthcare financed by taxes, but parts are. So for people who are lower income, we finance Medicaid through taxes. For people who are age 65 and over, we finance Medicare through payroll deduction taxes. We have no universal entitlement, but we do for some people. Anybody age 65 and over is entitled to Medicare, as well as folks that have certain other illnesses or disabilities. Folks who are veterans are entitled to health care through the Veterans Administration. So we have fragments, and we have critical issues related to cost, access, and quality. Now, it's not all bad. Our system leads the world in medical technology, in medical training, in research. We have really sophisticated institutions, products, and processes. We have folks who come from all over the world to get treatment in the United States. Our basic problem is that we have this really great healthcare, but we don't have a delivery system to get it to everyone that needs it. Kind of like a restaurant with amazing food, but really bad wait staff. And so what's the issue? Well, we're back to policy. Because in the area of healthcare delivery, every city, every state, and every country has to decide through its elected government, how much does it want to spend on medical services? What types does it want to provide? Every healthcare system in the world rations care. They just decide explicitly how they're going to do it. What are the best methods for producing those services, and what are the best methods for distributing them amongst the population? And mostly, how do these get decided? Policy largely gets decided based on the values of the society that exists within in democracies. And, in our society, we have a real clash of two kinds of values. So if I said to you, what is justice without this slide, you would probably say, well, justice is fairness, right? It's being fair to everyone. But I could push you and say, well, what does fair mean? In the United States, for many things, we believe that fairness happens through the free economic market. And market justice places the responsibility for the fair distribution of healthcare on the market forces in a free economy. So in terms of healthcare, the belief would be that interfering with market forces in the free economy would be considered unjust, that people will buy the insurance they can afford, that there'll be a demand for insurance they can afford, that there'll be a demand, that the demand for healthcare and the prices will even out so that healthcare will be distributed properly. It doesn't work that way because healthcare ultimately is not a free market item. But again, we'll talk about that in a different class. But the underlying value in the US is essentially you deserve the healthcare that you work for and can afford to pay. Now, social justice is different. Social justice emphasizes the well-being of the community over that of the individual. And for certain classes of people, for folks who are lower income, for senior citizens, for children, we also have that value, which is why we have Medicare and Medicaid and Children's Health Insurance Program. So with social justice, the inability to obtain medical services because of lack of financial resources would be considered unjust. Now, the only challenge with social justice, because no system's perfect, is who gets to decide. Right? Who gets to decide what care is being distributed? Who gets to decide who gets that care? Who gets to decide which individuals need that care? So even in a social justice system, it's important to examine the details to make sure that it truly is fair and equitable. So that is what I have for this particular video and introduction, and I look forward to the rest of the class with you.